have not gotten to. I'm admitting Chelsea right now.
Oh, perfect. And look at it. Without further ado, I'd like to call this September 19th, 2023 meeting of the Treatment and Recovery Subcommittee of the SURG to order. Kelly and team, if you wouldn't mind calling roll.
Absolutely. Kelly Marshall for the record. Assemblywoman Claire Thomas.
Here.
Chelsea Cheatham.
Present.
Dr. Leslie Dixon.
Here.
Lisa Lee.
Present.
Steve Shell.
Here.
Jeffrey Iverson. Madam Chair, we have a quorum.
Wonderful. Thank you, Kelly. I'd like to move to agenda item number 2, which is our public comment period. Public comment will be received via the Zoom meeting and shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to Nevada Revised Statutes 241.020. Any commenters? Well, I'll pass this over to you, Kelly, for further instruction.
Come on.
Thank you. Kelly Marshall for the record. So just a note for the public, if you're dialing in from a telephone from the United States, dial 1-253-205-0468. And when prompted, enter the webinar ID 894-8937-5298. And then please press *9 and I can prompt you to unmute. So is there anyone who would like to make public comment? Please indicate by either unmuting yourself, raising your hand, or dialing *9. Madam Chair, I don't see any indications of public comment.
Thank you, Kelly. We'll move on to agenda item number 3, which is the review and approval of minutes from our August 29th, 2023 Treatment and Recovery Subcommittee meeting. Looking for any motion or discussion.
Chair Lee, this is Steve Shell. I'll make a motion to approve the minutes from the August 29, 2023 meeting.
Thank you, Steve.
And Madam Chair, Kelly Marshall for the record. Laura Hale from the SEI team had a comment.
Oh, great. Let's hear the comment, Laura.
Thank you, Madam Chair. The draft minutes that I put together are labeled August 30th instead of the 29th. The meeting really was the 29th, and we will make that minor adjustment on the final. So I just wanted to make everyone aware of that.
Thank you, Laura. So we'll get a revision to the August 29th date. We have a motion on the floor.
Madam Chair, Kelly Marshall for the record. I don't see our DAG available right now, but I wonder if the motion needs to be called back and then revised to include with that change. So I'm just wondering if Steve needs to revise his motion to include the change to note August 29th instead of August 30th.
Sure. Would you like to revise your motion, Steve?
Yes, thank you, Chair Lee. Steve Shell for the record. My motion is revised to say that I'm making a motion to approve the minutes from the August 29th, 2023 meeting to reflect the correct date as noted in the draft of the minutes.
Thank you, Steve. We have a motion and a second by Dr. Dixon. All of those in favor, please signify by stating aye.
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 Are there any opposed? Any abstentions? All right, that motion to approve is unanimous. We will move on to the meat of this agenda. agenda item number 4, which we're just gonna deep dive right into our 2023 treatment and recovery recommendations for discussion. And so I believe this is the part of the journey where we switch to the handout. Is that correct?
That is correct. And just Kelly Marshall for the record. Madam Chair, I just want to note that Jeffrey Iverson has now joined us.
I see that. Thank you. So we have a full committee.
Good morning, good afternoon, everyone.
Good afternoon.
All right. Okay, so Madam Chair, I would just call the public and the subcommittee members' attention to one of the documents that was posted, which is the SURG Treatment and Recovery Subcommittee recommendations, September 2023. And we have
Rascal, come on.
Dr. Kearns, you're not muted.
Okay. So Kelly Marshall for the record, I would just note that I believe what we want to do is validate that the recommendation as written based on the person who sponsored it is intact as is, or if the subcommittee would like to make any revisions to that recommendation. And then we can go through, and I think the focal point that we wanted to do was to just have a discussion on urgency, impact, the capacity, and then the degree to which the recommendation advances racial or health equity. Madam Chair, I think we have two options. One is to go through the recommendations first and have a slate of them so that we can consider 2 recommendations that were not approved before we reached. They were not approved because we lost quorum at our last meeting. And then potentially we could go through kind of that consensus building exercise, or we could take it one at a time, seeking consensus as we go.
Thank you so much, Kelly. I'm up for any and all discussion from the committee members. My preference would be to go through them one by one. But I'm open. What does everybody want to do?
Chelsea Cheatham for the record. I like the idea of going through them one by one.
Jeff Iverson for the record. I do too. And I apologize, I missed the last meeting.
Thank you both. And I just want to thank Steve and Dr. Dixon for following through and putting those recommendations, adding them into the survey. We couldn't do that, this work without your work. So thank you so much.
Madam Chair, Kelly Marshall for the record. I would just note that Ms. Cheatham also submitted.
Oh, Chelsea, thank you. I'm sorry. Thank you. Perfect. So let's just go through them. This first recommendation, Kelly, if you could make it slightly bigger. I have a very small screen. Okay, perfect. So this one is around expanding access to medication-assisted treatment and recovery support for substance use disorder, limit barriers to individuals seeking treatment regardless of the ability to pay, and encourage the use of hub and spoke systems, as well as recovery support, including use and promotion of telehealth, considering the modifications that have been made under the emergency policies, and pursuing innovative programs such as establishing current MAT options in emergency departments. In this recommendation, if we scroll down, it has that full recommendation there, the justification and background for this recommendation. This one didn't really have any kind of peer-reviewed data or specific citations, and so I don't know if we have the opportunity to modify it. If anybody has any quick references, it does cite media reports of overdose data. I'm assuming that's those OD2A SUDORs reports that go out monthly, quarterly, annually. So if we want to cite that rather than media, cite our SUDORs data. Media reports. I'm not sure that that fully relates to this. I think there's a lot of published studies that this isn't my area of expertise, but I know that there are a lot of there's a lot of literature around it, like buprenorphine induction within emergency departments. There's even some local research that has been done. I know Femi did some research in this area across the state. He's a recently graduated PhD student. So I don't know if we wanted to include any of that. Dr. Dixon, this is kind of your bailiwick. If you have any literature.
I was kind of under the gun to get this done, and I have very limited time to do it. So I didn't really take the time to look up the literature. Yeah, my computer probably has a lot of it if I'd had the time to do a little search. But anyway, I mean, in terms of for the pressing, the reason I use the media though, because they are constantly bombarding us with all this reports. And so I think what they are doing is continuing to create the urgency of the whole situation. You go look in the literature, research literature, of course, you have science writing and it doesn't create quite the sense of urgency that the media is doing. But I think Kelly probably has some good ideas of what to put in, like the OD2A data keeps coming out, and I don't know, I don't know where, I mean, yeah, I probably have some articles on that too, on the buprenorphine induction in the ED. But I didn't have time to do a search.
Madam Chair, Kelly Marshall for the record. I know that you also mentioned Femi, and I'm not sure how to indicate that. Is it just?
I'm actually looking for his full name. I know 2 PhD students called Femi. And so I'm trying to figure out which one it is. So one moment, and I can probably put a link to an article I can email you that. How about that? Okay. So I don't know. I mean, the question is really to this board, do we want, I know is it in SB 390, or if it's the one that guides ACORN, I think that's AB 374. Is that correct? Does that ring a bell? I don't actually know the bill that governs the ACORN. I think it's that. Somebody please help me, save me. What is the correct bill number? AB 374?
Laura, Kelly Marshall for the record, Laura, do you have a sense of that? Is it AB 374 for ACORN? Or Joan Waldock just joined.
Oh, perfect.
And I believe Joan has a relationship with ACORN.
The original bill that formed ACORN was Senate Bill 390. Is that what you're talking about when it was formed? I had to hop into the meeting late.
That's the one that guides us, right? Senate Bill 390.
I thought it was the one that did ACORN.
Senate Bill 390 is ACORN.
Oh, great.
Yeah.
Okay. So
Yeah.
Senate Bill 390, what is the one that guides us?
It's Assembly Bill 374, I think.
Okay. So I just had those flip-flopped, AB 374. So and I can't remember which bill it's in, but there was a link to evidence-based practices or evidence-informed practices. And so we know that MAT is an evidence-based practice. We know that the bridge program or buprenorphine induction within emergency department settings is one that's well studied. And there's evidence around that. So I don't know if how y'all feel about adding some evidence to this, or are we good as is? I'm good with whatever you all decide.
This is Chelsea Cheatham. I agree. I think we probably should put some more research links and information behind this. Lisa, I liked your idea of including the buprenorphine induction and ED programs literature. I was trying to look to see if I could find anything that had been cited that I could find pretty quickly, but I can't find anything right now. So I'm gonna have to look for it and probably email it.
Thank you, Chelsea. I'm also scouring right now.
So Madam Chair, Kelly Marshall for the record, if people were able to provide links and just reference the recommendation, so this is recommendation 1, then we could update this handout to insert those links, and then that would be carried forward into the annual report, assuming that the SURG adopts this recommendation.
That sounds great, Kelly. And just, for this written record, the FEMI that I was citing was Dr. Olufemi Ajumobi. And I will be sending you some of his publications.
Kelly Marshall for the record, I just probably butchered that spelling, but we can insert that once we have the link.
It's pretty close. Olufemi, last name Aju. Mobi. Okay, perfect. So we'll get some, I think between all of us, if we send a couple of maybe recently published articles to support that, just think it would have some more teeth. And then if we could scroll down
This is,
to, oh, I'm so sorry, Jeff, go ahead.
no, I was just gonna say, this is Jeff. I just found an interesting article published by NIH that I sent to the group. I sent a link.
Thank you so much, Jeff. If we could scroll down to the scale right there, I think these are the new pieces. If we could just have a little opportunity for everybody who presented a recommendation, moved a recommendation forward in this document, just a brief rationale for your scoring to the group, I think would be fantastic.
The 1 to 3, there's 3 was the highest level, right? Hopefully, I think I used it right.
That's correct.
Oh, well, I mean, basically the problem hasn't gone away. It's getting worse. We have more and more overdoses all the time. And so I would give it a 3. I'd probably give it a 3 plus if I could. It's just
Kelly Marshall for the record. Dr. Dixon, I'm just taking your notes and putting them down here as part of your description.
mhm.
So I guess if I can ask Dr. Dixon, on that last piece, so you rated it a 3 on a scale of 1 to 3 for urgency. You rated it a 3 on a scale of 1 to 3 for impact. And then the last part is the current capacity to implement your recommendation. You rated it as a 2. And so I'm wondering, I guess the question for me is what needs to happen to bring readiness to Nevada's system to adopt these recommendations?
Well, we need more prescribers, which, and we get to the other one, I have something to say about that. People who are trained to take care of folks with these problems, and people who are comfortable doing it, prescribing, trained and comfortable, because there's more to being than being just trained. People have to want to do this, and they have to be comfortable working with people with opiate use disorders, which is just not a lot of the medical profession. And but anyway, so they're not. We need to have more people trained and comfortable working with people with opiate use disorder, OUDs, and then we need to have what is the second one? The second one here?
Impact.
Well, the impact is high because we the use is of heroin and fentanyl, and then I was hearing yesterday about carfentanil, people using that. The use is increasing clearly, and we so yeah. And I don't know why I chose 2 instead of 3 for the other one. Maybe because it didn't have quite the urgency to me. I don't know. The current capacity is obviously not too good, but it's more than I think people realize. It's kind of like, I've been doing psychiatry for 30 years, and it kind of hurts every time people say there's not enough. I can't find a doctor. And meanwhile, we have, these programs, we have increased and increased and increased the number of people, and yet we get the same message over and over. There's not enough. There's nobody else. And it's not as bad as it was when I came here. So I guess it's not as bad. I think it's at this point, the bigger problem is getting the word out, getting people to be aware that there is treatment, and people to know where the treatment is. So.
This is Jeff Iverson. For the record, may I make a comment?
Absolutely, please, Jeff.
Hi, everyone. I don't know if any of you know this, but I'm the CEO of an agency in Las Vegas called Crossroads of Southern Nevada. And we have a 75-bed detox center, primarily for the Medicaid population. My detox beds are full every single day. In the last year, we've really increased our MAT protocols, both in detox and in our long-term programs. The idea of buprenorphine in the emergency rooms is absolutely, I think, a crucial element to combating this epidemic. But and I would like to validate everything in Dr. Dixon's recommendations here. We need to expand capacity. I started out with 55 beds in my detox clinic, increased it to 65. I've increased it to 75 now, and it just doesn't ever seem like it's enough. We're right across from UMC Medical Center on Charleston. And I really think it's these recommendations are great, but we really need to focus also on getting people into a continuum where there's a shot at long-term success here.
And I want to add something to what Jeff just said, that, Crossroads has become almost the only thing we have now, because, particularly for the Medicaid populations, people with good insurance, there are a few other programs, but it was made worse just recently because WestCare had to close its CTC, and so we've lost a very important detox option. And
Jeff
so,
Iverson for the record again. I just share an interesting fact with you guys. About 4 months ago, we started testing everybody coming through the door for fentanyl, regardless of what they were self-reporting. And 50% of people that reported only using methamphetamine were testing positive for fentanyl. Meaning even prior to that, like we're not even using the proper protocols to get them detoxed right. So like I can get behind this recommendation in a big way.
Thank you both. I think it's important to hear from you both on kind of what's going on in Southern Nevada. And I want to be mindful, to your point, Dr. Dixon, about not being able to get psychiatry or, medications. And that's, what you're saying isn't true for the entire state, right? We still have these huge provider shortage areas, and you're in this, really our largest metropolitan space in our entire state. And it still sounds like everybody's kind of at capacity. And then there's places across Nevada that are really struggling for access. So I just want to kind of think about that urban rural disparity, right? And then I also wanted to just bring up in this conference presentation that Femi presented, he stated, well, and it's Femi and others, right? It's Dr. Friedman, Dr. Westhoff, Dr. Granner, and Dr. Wagner. And they state to scale up buprenorphine program implementation in Nevada EDs, there's a need, one, and this is out the door now that the X waiver is gone, but I'll just read it as is. One, staffing that ensures there at least an X waivered provider per clinical shift. So now I guess that recommendation would probably be a willing and able provider to prescribe buprenorphine, being as the X waiver is out. And then two, more access to insurance. Three, physicians' participation in collaborative learning platforms such as providers clinical support system. I think that's a reference back to Project Echo. And then four, creation of outpatient pharmacy in the ED. And I know that is truly a barrier to a lot of hospitals implementing, is that how their pharmacy is. And if they can prescribe that outpatient medication, or if people have to come to the ED to get that medication. I know that's a barrier in some of the hospitals. So definitely want to keep those things in mind. And I think you were spot on, Dr. Dixon, with your scoring, the rationale for not giving it a 3. Like we're not widespread ready to implement. And I think of hospitals like Mount Grant, which they do have a MAC clinic at Mount Grant in Hawthorne. I think of other hospitals, South Lyon Medical Center, for example, in Yarrington, places that have been hard hit, Banner Churchill, all of these rural hospitals, and their ability to really work at capacity there. So thank you all. I don't know if you want to add anything, Steve, from like the Renown point of view, or Chelsea, if you want to add. You've done a lot of work across rural Nevada with buprenorphine induction and access. I think you both would have really wise things to say on this.
Chair Lee, Steve Show for the record. Not a really whole lot to add to what all of you have already said, other than the fact that we just need more of it. But I do like the fact that we're focusing on not just the urban areas, but the rurals. We get a lot of referrals and the Renown system from the rural areas, which clearly indicates, the access is not great. But nothing else really to add, though. Thank you.
I did want to say that when up above the numbers, there was an estimation of how much it's going to cost. I pulled that totally out of the air. I have no idea what any of this would cost. It just sounded like a good number to me. So if someone would think that we need more, I'd be delighted to put more in there.
Thank you, Dr. Dixon. I was actually curious about your methodology. I thought you were brilliant. I was like, look at you go. I have no idea. Right.
I don't either. I suppose there's a calculation that could be made that might tell us something, but I know I don't have any idea. So,
Madam Chair, Kelly Marshall for the record. The pieces from Femi and others that you cited, if I'm not incorrect, and Laura Hale will hopefully correct me if I'm wrong, but I believe there is a place in the report, in the annual report, assuming this recommendation gets included, that includes action steps. And I wondered if the things that you were reading, you know, such as installing, you know, providers in the emergency department to prescribe. So I see a thumbs up from Laura. If those wouldn't be part of the action steps that could be added, if this group agreed.
Thank you, Kelly. I think that that is an excellent suggestion since somebody's already done the research in our state relatively recently. I think it's wise to connect research to policy implications and practice whenever possible, especially if it's recent research. So if you all are good with sort of those action steps as a recommendation, again, pointing out that, you know, since the X waiver isn't a thing anymore, then obviously we would remove that piece of the recommendation that's, you know, that's changed due to policy.
well, let me say something about doing away with the X waiver. It's true that people don't have to do the X waiver to prescribe buprenorphine, and theoretically anyone with an active DEA could prescribe buprenorphine. But in order to maintain your DEA, you have to have 8 hours of training in substance abuse, and which presumably would have a lot to do with opioids. And so it's kind of like, which is good. I think is good. Medical training and training in other fields has never been really good on substance use disorders. And so requiring everybody to do it if they want to keep their DEA is a good thing. So we've kind of traded the waiver for mass training. It's kind of funny. Anyway.
Yeah, great point, Dr. Dixon. Okay, so bringing it back to this recommendation, how do you all want to do that? Do as far as like vetting these through? Would you like to kind of vote on each one or go through them all and then at the end kind of reel it back and see which recommendations we're going to move forward? What's the consensus?
This is Chelsea Cheatham. I think since we're having discussions on each one, it would probably be easiest to just vote on each one. So after we're done discussing everything, we kind of have a plan of things that we need to add and change and update. Then we just kind of vote on them and make the changes. And then we know that that one is going to be submitted and pushed through.
Perfect. Does anyone disagree with that?
Everyone froze for a minute. So what did you all decide?
Oh, we're still deciding. So I'm just wondering, I mean, that sounds like a great idea to me while it's fresh in our minds. But if anybody has a different idea. All right, well, let's move on this. So I guess the call would be for a motion to move this recommendation forward with our subcommittee recommendations for the SURG meeting to be included.
Madam Chair, Kelly Marshall for the record. I think it's with the additions of citations as we're able to insert them and the updated justification that was added for impact, capacity, and advances racial and health equity, as well as urgency.
And the action steps.
And the action steps.
So I guess move this recommendation forward with the amended pieces from our discussion with that some. Okay, so that is, if anybody wants to move on that.
Well, I'll make a motion then.
Jeff Iverson, for the record.
All right, so I heard a motion from Dr. Dixon, a second from Jeff.
Yes.
All right, all in favor, please signify by stating aye.
Aye.
I did not hear any opposed. Motion carries unanimously. Yay, okay, moving on to recommendation 2. Oh, look at Dr. Dixon. This one also was submitted by you. Implement follow-ups and referrals and linkage of care for justice-involved individuals, including individuals leaving the it should be justice system, I believe, and that is complete in that next box there. Leaving the justice system. And just to ring a bell for everybody, at our last meeting, this was a recommendation from 2022. It also included the child welfare system. We decoupled the child welfare system, I believe. Oh no, it included pregnant people with opioid use disorder. That's what it did. And we kind of, you know, unlinked those two. And now we're just focusing on justice involved individuals with the work that still hasn't been done through statute. We had some policy changes, but there are still some gaps. Is that accurate? Okay, awesome. Do we have any discussion around this recommendation?
Well, all right. Well, so I wrote it in here, the justification about what happened with AB 156, because that was in some of the original writing, that AB 156 wanted to mandate treatment, but that got taken out. And they put this change at the very end of the bill. If you read the bill, it's section 17.5, where all the things involved in the justice system, the little jails in the rural counties up to CCDC, have to do some kind of, I forget the data they're supposed to collect, but they're supposed to collect a bunch of data and then write a report. And I guess based on the issue of substance abuse in the jails and stuff, and write a report that has to be sent to the LCB by June of 2024. And so presumably this would be an opportunity to rethink a bill and design a new bill from the data. Now, I find it very problematic asking, and I got this from Dr. Wade. I actually consulted with Dr. Wade on some of this, and basically, Dr. Wade is the medical director for NAF care for much of the western part of the United States. So he knows what's going on in a lot of jails, not prisons, but jails. And he says, but he works with the jails. He knows what's going on in the prisons too, but he doesn't work with any prisons. Anyway, he says there's just really not much interest there. And so that's why they pushed back and said they didn't have the money to do it. And so I don't know what we're going to do about getting a bill. I forget whose bill this was. I think it was the interim healthcare committee put this bill forward. And that was probably based on people that went and testified to the interim healthcare committee. And so that's what's happened with the idea of justice system. And then, which is not in our recommendation, but I do think you all want to know this in case you don't, is that Senator Stone somehow managed to get a new part put into the bill, section 12.3, I think. Yeah. That pharmacists can prescribe MAT now. And that went right, that sailed right through apparently and got signed by the governor. We did not, I was not made aware of this. It happened next to the last day of the session. It was not heard in any kind of public testimony. It was a behind the scenes kind of a thing. So anyway, I have been working a little bit with and interacting with Dave Weiss from the Board of Pharmacy, and then Dr. Riccio on the regs for the pharmacists doing this. I don't know. It's really kind of I guess like a bit of an insult to those of us who spend our lives taking care of these patients to think that a pharmacist can do an adequate evaluation and diagnosis and then put a treatment plan together that's going to really make a significant difference in someone's life. That's my bias anyway. So I don't know. I think we need to watch these bills a lot more carefully than we were doing, I guess.
Thank you, Dr. Dixon, for that explanation. I think, bringing us all up to speed on what happened with that. If we could just scroll up a little bit, I'm sorry.
If I could just interject real quick.
Yes, please.
Dr.
Please.
Dixon, if you could contact me, and this way we can speak with the chair of HHS and possibly address that next time.
Sure.
All right, thank you.
Mm-hmm.
Thank you, Assemblywoman Thomas.
But anyway, back to the justification. Yeah, these people they should be treated while they're in the system.
Mhm.
The only thing we're doing right now with the company I work for is that we do deliver methadone and buprenorphine to our patients or patients that are already on either one. We do deliver them to the jail for those individuals. We don't initiate treatment, nor does anybody there initiate treatment, but we will deliver buprenorphine and methadone to the jail.
For continuing treatment.
And I think they're doing that up in Reno also.
No, actually, we have an NTP inside our jail that prescribes and inducts treatment. They do methadone, buprenorphine, and naltrexone. And so it's a full-fledged NTP, which is a narcotics treatment program for those who aren't familiar with the all of the acronyms that we speak. So that is within our Washoe County jail. So if it used to be continuing treatment, like to your point, Dr. Dixon, and so the OTPs or opioid treatment programs would drop off and deliver medications. Now, if I'm coming in and I'm showing symptoms of withdrawal, or whatever stage I'm in, maybe I just want a security policy and I'm already detoxed, right? And so they might start me on naltrexone, but they can do the induction right inside the jail.
That's good.
Very progressive.
Yeah, I don't know when that's going to happen down here. As you know, CDC is pretty darn big, and it would anyway.
Yeah,
we've got over 3,000 inmates.
So that's kind of what's going on, and then there's actually a position. There's an MAT care coordinator that coordinates that treatment when they're being released back into the community so that they can have continuity of care with one of the providers, community-based providers, whether that's through an opioid treatment program or an office-based opioid treatment provider. So I don't know if that's the recommendation, like, I guess, follow-ups and referrals, linkage of care. So now we have Medicaid, right? I'm just wondering, like, how can we leverage some things we have for this recommendation? So now we have Medicaid, is that correct? We have Medicaid benefits that start 90 days before release. Is that correct? Did that pass?
There
Chair
is,
Lee, this is Terry Kearns. For the Medicaid 90 days pre-release for SUD for incarcerated individuals, that has not passed yet. I think that DHHS is in the process of looking to apply for that. They did, however, get the 1115 waiver for SUD treatment. It's not necessarily just for people who are incarcerated, but they're still working on it.
Perfect. And so just to reflect a little bit on that, the 1115 waiver is a waiver to the IMD exclusion. Is that correct?
Yeah, that's correct. And I would
Okay.
also add, just for the information of the committee, as part of the state plan from the needs assessment, former Captain Bill Teal, who was with Las Vegas Metro and who was instrumental with the MAT program at Clark County Detention Center, has been doing an assessment of the rural jails to see where they are in terms of readiness, or do they have MAT programs, or what are the gaps and those sorts of things. So it's anticipated that that report will be done hopefully January of 2024.
Thank you so much for that information. I think it's helpful to kind of know where we're at, what is to come, and where the gaps are. And so looking at this, is there an opportunity to again include, sorry, I actually got dizzy from that scrolling.
I'm sorry.
I was like, whoa. If we could just scroll down a little bit to, I'm so sorry, the associated researcher links. Is there an opportunity to include what Dr. Kearns just said about the needs assessment and sort of moving forward on, I'm assuming it's like a feasibility and acceptability study. Is that correct, Dr. Kearns?
I'm not sure exact. I know it's like an assessment, so of the rural county jails. So it's probably needs and feasibility would be a good description.
Okay. And acceptability, are they also looking at how open these rural detention centers are to the idea of?
Yeah, and that's part of is do they have a capability? If they don't, what's the impediment? For example, some places don't have a provider, so could that be implemented through telemedicine and those sorts of things?
Okay, so it is kind of an acceptability and feasibility study. Okay, perfect. And is anyone aware of, again, this is not my topic that I know a whole lot about. If anybody has any research that they'd like to share on what this looks like in a healthy system with justice involved persons.
Well, I think we could at least do the link to AB 156 enrolled person.
Perfect.
This is Chelsea. So in my previous work working with Track B, we did work with people that were in a few of the county jails, and what we did was it was more of a mobile thing where we had a licensed drug and alcohol counselor travel with us, and they would do the assessment with the person while they were in jail, and then they would be able to get the buprenorphine while they were there with a local provider. And then when they were getting out, they would be working with a someone that the licensed drug and alcohol counselor would connect them with. So usually it was a peer recovery support specialist that would then link them with a program in the community that would be able to continue their medication.
Thank you, Chelsea. You've done a lot of work across the state. Thank you for adding that. So I think to move us forward, we can look for if anybody wants to move to approve this recommendation. And the motion would need to include any kind of amendments that we've made to that during this meeting.
Charlene, Kelly Marshall, for the record, I just wondered if you wanted to look at the ratings and those areas and see if there was anything to be built out. Or if the group agrees with those scores.
Kelly, thank you so much. I was remiss in bringing that up. So, Dr. Dixon, thank you again for submitting this recommendation. Looks like you rated it a 3 out of a 1 to 3 on urgency, a 3 out of a 1 to 3 on impact, and a 1 on current capacity to implement.
That probably isn't the right number. Current capacity to implement would be, if we had the capacity, would that, and we felt good about it, would that be a 1 or a 3? So
It would be a 3.
3. It
If
would be
you
a
felt
3.
like it was fully built out. Sorry, Kelly Marshall for the record.
So a 1 would mean that the capacity is not very good.
Correct. And that would include funding to be able to implement this recommendation in with incarcerated people.
Yeah.
Any further discussion on those scores?
Jeff Iverson for the record. Can you guys hear me?
Yes, please.
Oh, I'm sorry. I just want to say that from a boots on the ground perspective, an enormous percentage of people's introduction to the idea of recovery happens within the criminal justice system, especially in incarceration. So I like all of this. I could really get behind all of these recommendations as well. And I think that a 3 for the current capacity would be correct.
A 3. So saying we have capacity across Nevada to implement this.
If we had the funding.
So where are we now without that funding?
Oh. It sounds like there's some of this happening already. I don't have enough information to actually make that recommendation or determine or give an answer to that.
Okay. So are we good with leaving it at 1 for now?
Aye.
So Kelly Marshall for the record. So 1 meaning we don't currently have the capacity to implement the recommendation as is without some kind of.
I think that stays a 1. We know that every county and has a jail and, and whatever. And, I can't even find out if there's anybody working at High Desert Prison, let alone the jails. So yeah, I don't think we have the capacity. We don't have, in fact, we're going to try to do something with correctional psychiatry to get people more interested in it. But, so I don't think we have the capacity to do very much. I think it's great that there's something being done. That's good. So, but
Thank you, Dr. Dixon. I think, Lisa Lee, for the record, I have some folks in my personal life that, are clinicians that have worked in the prisons, and, their caseloads were, terrible. Like, it really, their caseloads were so high that, it gave them about 15 minutes per person per month to do psychotherapy. And that is just like, what could you possibly do for 15 minutes a month to really move somebody towards coping skills and strategies and all of the things for when they get out? I mean, it's just the caseloads are way too high. So so I would also rate it a 1 for capacity to implement. And I've got a few friends inside right now, and from what I'm hearing, it's we are not in a place where we could be inside our system. And so I would agree with you, Dr. Dixon. How are we feeling about moving this? Oh, Terry Kearns, I see your hand up. Sorry.
Yeah, I'm so sorry. I just wanted to add that in the last legislative session, when AG Ford had pushed forward the legislation on the weighting of fentanyl, and then he added implementation of MAT in jails and prisons. Some of the feedback that was received was that, we do have it in Washoe, we do have it in Clark, we have it in a few other places, but many of the rural frontier counties said it wasn't just a funding thing. They just also didn't have personnel or trained personnel to be able to implement MAT programs. So I think the capacity statewide is low.
Thank you so much. I think it's always good to hear how we're doing broadly across our state, rather than, like, Clark's doing great, Washoe's doing great. You know what I mean? So thank you for bringing that point up. What do we think about moving forward with this recommendation? Again, I will invite all of you if you'd like to make a motion to move this one forward, or if we need more discussion.
Madam Chair, Kelly Marshall for the record. I just wanted to note that I think some of the traditional literature on racial disparities and therefore health disparities for disproportionately represented populations in the jail would address the advances racial and health equity component.
Kelly, thank you. I think that is an absolute necessary point to any conversations on incarceration and mass incarceration in this country. I know I've been fired up the last 2 days at Mobilized Recovery talking about this very issue, and how our country has really used the same hammer to address, we don't incarcerate cancer out of people or incarcerate hypertension out of people, and yet we try to incarcerate addiction out of people, the disease of addiction. So we definitely need to talk about that and how drug policy has been absolutely racialized in this country as well. So thank you so much, Kelly. I don't think we talked about the health equity component in our last recommendation, but if somebody could please give that reminder for the rest of our recommendations, I think we need to address that as well. Thank you, Kelly. Now I'm all fired up.
Kelly Marshall for the record. I would just ask people to look away from the screen right now while I scroll up back to the recommendation. There we go.
Thank you, Kelly. Okay. How is this sitting with everybody? Are we ready to move it forward?
This is Jeff Iverson for the record. I'll make a motion to move it forward.
And this is Chelsea Cheatham. I will second that motion.
Great. And I'm assuming, I don't want to assume, so I'm going to ask. And your motion, does that include the recommended amendments that we've discussed in this meeting, or as is?
Yes, with the recommended amendments.
Perfect. Thank you. We have a motion by Jeff and a second by Chelsea. All in favor, please say aye.
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 Hi.
And I heard that unanimously. So motion carries to move this recommendation forward. We'll go to recommendation number 3.
All right, I'm Kelly Marshall for the record. I'm trying to spare you all watching me move. There.
All right. Oh, look at, I submitted this one. Okay, great. This recommendation is to implement a specialized child welfare service delivery model with follow-up and referral and linkage to care that improves outcomes for children and families affected by parental substance use and child maltreatment and pregnant or birthing persons with opioid use disorder. So this is, again, I think we made modifications to a couple of previous recommendations to put the things that go together in one recommendation. So we took out the pregnant or birthing persons with opioid use disorder from that justice involved persons recommendation that we just passed to move forward. We added it here to this specialized child welfare service delivery model, which we took out of another recommendation that was related to increasing beds for youth. So again, kind of putting our population specific recommendations together. And then if you want to scroll down, I did include, this is the topic of my dissertation. So, and something I've been working on within our Washoe County system, the sobriety treatment and recovery team model. And so there are several articles that pertain to this growing crisis of families separated because of parental substance use. Currently, it's about almost 40% of children that are removed nationwide. And we see sort of fluctuations across Nevada. Washoe County actually has the highest child removals due to parental substance use, higher than the state and higher than Clark County. This is especially true when looking at infants that are removed. So thinking of those formative months and first year of a child's life and sort of the ongoing implications of family separation due to substance use. And so if we want to discuss this, or I can kind of offer the rationale for the rating.
Sure.
I would say, please look away. This is Kelly. For the record.
Thank you, Kelly.
Okay.
And I can explain my rationale and then leave it open to you all to adjust. I rated this a 2 because it's not urgent for everyone. So thinking of a population, it might be urgent for some, but not everyone across Nevada. I kind of feel that with all of these recommendations, it's like, yes, it's urgent for that specific population, but when you kind of draw that lens back and look at substance use across Nevada holistically, families is not this, the whole of it, or family separation. So I rated it a 2. And then the impact, I rated it a 3. Actually, if you scroll down a little bit, I put the rationale in the survey response. So for urgency, I said 25.8% of children were removed from their families in 2022 with parental substance use as a factor for maltreatment, and 2.5% due to prenatal substance exposure. Rated 2 for urgency due to only affecting pregnant and parenting persons with substance use disorders. The impact, when pregnant and parenting people address their problematic, chaotic drug use, it positively impacts their children, the schools, the society, as intergenerational cycles are broken. Rated 3 to the intergenerational breadth of the impact, as well as the impact on child welfare, schools, and juvenile and adult justice and treatment systems. When families recover, communities recover. The capacity to implement. Child welfare is notoriously a difficult environment to retain staff. Much of the state is a treatment desert, and we are hemorrhaging foster beds. Rated 2 due to these barriers. And then advances racial and health equity. Racial disparities in child welfare have been widely noted in the literature. Organizations like the Annie Casey Foundation, the Sobriety Treatment and Recovery Team model, has promising evidence that it promotes racial equity in the child welfare system, interrupting intergenerational cycles, advances health equity. And there's no rating system, but I would have rated this as a 3, given there was a recently published study by Thomas and others, 2022, I believe, that talked about 53% of Black children will have a child welfare case by or child welfare involvement by their 18th birthday. And I just I find that absolutely horrifying. And so that there it is, and I'll leave it open for all of you to discuss. Thank you.
Assemblywoman Claire Thomas, for the record. Chair Lee, could you please repeat that stat again at the end of your summation of I believe it was the treatment that was it children or people of 18 years?
So of all Black children in the United States, by their 18th birthday, it was 53% of Black children will have some sort of child welfare involvement with their family by their 18th birthday. And I can send out that it's actually a policy memo. I'd be happy to email that to you. But I just find that that pretty horrifying.
And Assemblywoman Claire Thomas, for the record, yes, please. I think that would be shared data. And I don't know, where did you get that from?
I believe I got it for the National Center on Substance Use and Child Welfare.
Thank you.
You're welcome.
Jeff Iverson, for the record. I will make a motion to move this forward if nobody has any other comments or questions.
I will second that motion.
Thank you. We have a motion by Jeff and a second by Chelsea. All in favor of moving this recommendation forward, please signify by stating aye. Aye. Any opposed? All right. I thought I heard unanimous, but I wanted to check. All right. This carries unanimously. We will move on to recommendation number 4. And Chelsea, thank you so much for submitting this one. This one is to establish priority funding areas to ensure entry into treatment and/or recovery, to ensure that Black, Latinx / Hispanic, Indigenous, and people of color and LGBTQIA communities are receiving culturally and linguistically appropriate overdose prevention, naloxone, vending machines, media, drug checking supplies to reduce fatal overdoses among BIPOC and BIPOC communities in Nevada. And I will turn it over to you, Chelsea.
All right, thank you. So, in my survey response, I basically just copied what was up there. We added BIPOC on there to make it a little bit easier and combine everything together. And what I did was I took the 2022 recommendations and I just incorporated some of the things that we heard in presentations this year. So to prioritize programming and funding specific to organizations reaching BIPOC community members, promoting diversion and deflection programs for historically marginalized people, engaging BIPOC people and organizations in campaigns, billboards, and messaging related to substance use, support and implement the track the harm reduction model, so the vending machine model, with funding for staff and infrastructure to stand up newsstands and vending machines for harm reduction. That was taken from the Black Wall Street presentation. Also to stand up peer recovery support specialists independently of treatment with targeted funding, and then to support PRS's training events, including Train the Trainer, with technical support for other trainers. So really it's to fund organizations that are already trusted entities within the BIPOC community to conduct overdose education, naloxone distribution, and to direct DPPH to create grant opportunities for organizations to provide overdose prevention.
Oh, it continues, sorry.
No, you're fine. And yeah, that should be for BIPOC communities, I think. Overdose prevention for BIPOC communities. Oh, yes, sorry. Direct DPBH to allocate funding to projects that are specifically conducting outreach to BIPOC communities to ameliorate the harms of substance use disorder. All right, so for justification, we have some information in here about surveillance data in Nevada, so that OD2A report that comes out, also fatality data in Nevada, and then the presentation that we had with local outreach efforts in Nevada that have been successful, which was the Black Wall Street presentation.
Just say, look away for right now. There we go.
Thank you. So on a scale of urgency, I put this one as a 3 because, you know, people are dying. So we want to make sure that this is going to be a focus of just being able to stop unnecessary overdose death. The impact of our recommendation is definitely going to be a 3, saving lives by, you know, making sure that people are able to get harm reduction education into all communities in the state of Nevada. And I think our capacity to implement is actually a 3. I think we've got some great harm reduction organizations and individuals that are doing some really good efforts that are already working in communities that would be able to really move some of these things forward. So peers in various counties, we have community health workers in almost every county, as well as we have our prevention coalitions that are, you know, holding those coalition meetings and bringing the entire community together to talk about substance use. And I think they would probably be able to also help to implement a lot of these recommendations in their community.
Awesome. Thank you, Chelsea. Beautiful.
Thank you.
And do we have any further discussion? And if not, let's throw a motion out there.
Jeff Iverson, for the record, I will motion to move this forward.
Thank you, Jeff. I don't know if I'm allowed to second as the chair, but if I am, I would like to second that. I'm not sure if I'm allowed. I know I can't put forth a motion, but
Rosa,
Can you hear me
our
okay?
dad is here. Yes.
As far as the law is concerned, you can make motions, you can second motions, you can vote. The open meeting law itself treats all members the same for purposes of voting and motions.
oh, wonderful. Okay, well, I would like to second that motion. And so we have a motion by Jeff, a second by myself, Lisa Lee for the record, and we will move to a vote. All in favor of moving this recommendation forward, please signify by stating aye.
Aye.
Aye. I did not hear any opposed. Is there any opposed? All right, this goes unanimously forward. And we will move on to our recommendation 5. And so this recommendation seeks to significantly increase capacity, including access to treatment facilities and beds for intensive care coordination to facilitate transitions and to divert youth under the age of 18 at risk of a higher level of care and or system involvement. And I will turn this over to Steve.
Thank you, Chair Lee. Steve Shell for the record. So I think we can probably all attest to the fact that capacity is an issue around the state. It's greater in some areas than others, but the fact remains that we still have individuals backed up in our emergency departments around the state that can't get the access to care, that they deserve. So that's one of the reasons why I wanted to move this one forward. And I don't know, Shirley, we could, if you want to scroll down, or if Kelly could scroll down a little bit. Yeah, so in terms of the urgency, I rated that a 3 just because we do know for a fact that we have people not getting the care that they need. They're being sent out of the areas where they live. Some are being even sent out of state. So in my mind, that it's a very urgent matter that people aren't getting the treatment they need, which is ultimately leading to deaths around the state. And I think the impact of the recommendation is also a 3 in my mind, just because this would ultimately save lives and get people the treatment that they need on a much earlier basis. But in terms of the current capacity, I rated it a 2 because we don't have enough beds and enough programs around the state. So we do need more treatment beds and more treatment programs. So that's why I rated it a 2. I think we have a sufficient number, but we still don't have enough to be able to build on. So that's why I had ranked it as a 2, but I'm certainly open to what my fellow committee members think on that.
Thank you so much, Steve. I think you're spot on, and definitely evidence shows that if people are able to get into recovery earlier, they're more successful later. So this is spot on. Do we have any further discussion or any kind of proposed amendments to how those were rated? Steve, my only question is if we could scroll back up slowly. Thank you, Kelly. Oh gosh, let's see. It is, it's further up. I'm sorry.
Okay, look away, please.
Right here. So these associated research or links, I think when we decoupled the child welfare from this recommendation, they were together. I think some of those associated research things kind of lingered on, and I'm wondering if this could be an opportunity to get rid of those.
Great point, Chair Lee. This is Steve Shell for the record. So what I did is I did not spend as much time as those as I probably should have. I just carried forward what we had previously submitted.
Okay, perfect. Yeah, I think if we just got rid of all the ones related to child welfare. And then Steve, I wonder if this is an opportunity. Remember when the Justice Department investigated our youth treatment facilities, our residential treatment facilities in the state of Nevada? I'm wondering if this is an opportunity to include that, because I think that that has a ton of evidence.
Oh, yes.
Right.
Excellent point, Chair Lee. Thank you. That definitely needs to be included. Yes, because that investigation is still undergoing. So,
Well, I think it was very eye-opening to all of us across the state. Like, wow, this is where we're at. So maybe we could include a link to that report.
excellent. And then Shirley, I wanted to note as well that I did not put a fiscal note on this. I did mark unsure there. That's a tough one for me, you know, like putting fiscal notes on the rest of our recommendations, you know, it can never be enough. But I think it has to be enough to incentivize organizations to provide this level of care, to expand their existing services, as well as to prevent the cherry picking that happens around our state as well. We have a lot of facilities that deny individuals the care that they need for various reasons that are for financial reasons. So I left that one as unsure just because I wasn't, you know, quite certain about how much to place there. But again, I'm open to whatever the group thinks.
Well, Steve, I'm also unsure. I think Assemblywoman Thomas would probably have the most. Oh, I see Kelly's hand up.
So Kelly Marshall for the record. So just because I've worked on projects related to the DOJ investigation, my understanding is that the state will either come to an agreement with the Department of Justice, or the Department of Justice will sue the state and compel them to invest X number of dollars. So I'm not sure it requires a separate calculation. It may be that you reference that it should be determined as part of the negotiation between the state and the Department of Justice.
Assemblywoman Claire Thomas for the record. Laura put a great recommendation in the chat. And just from prior experience, DHHS is a good source to see where the fiscal notes.
Thank you so much for that information. Okay, are we ready to move on this one? Is there a motion to move this one forward?
Jeff Iverson for the record. I will definitely make a motion to move this one forward.
Okay, and again, I want to clarify a motion to move this forward with or without the discussed amendments from this meeting.
The discussed, I would suggest, I believe that the information about the DOJ and the investigation is important.
Perfect, thank you. We have a motion.
This is Steve Shell. I'll second the motion. Thank you.
And a second by Steve. All in favor, please say aye.
Aye.
Aye. Any opposed? All right, motion carries unanimously. Look at us all agreeing, all consensus like. This is fantastic. Do we have any more? Sorry, my papers are all discombobulated. Oh, this is me. All right. Okay, so the last recommendation here, and then I think we're moving on to the ones we didn't get to last meeting on our next agenda item. So this is recommendation number 6. Engage individuals with living and lived experience in programming design considerations and enhance peer support for underserved populations to be delivered through representatives of underserved communities by increasing reimbursement rates, implementing train the trainer models, and enacting policy changes to address limitations to the use of peers in some settings through strategies including ensure adequate funding for these priorities, target special populations, increase reimbursement rates, and offer standalone service provision opportunities. And then I submitted this forward. This was based on presentations that were provided by Black Wall Street and Foundation for Recovery. And so the justification was relevant and timely information about current substance use trends in communities at the level where these trends occur, i.e. by talking to people with living experience. The people closest to the issues are always the ones with the solutions to the issues. Alignment of services to needs and preferences of the person seeking or receiving services, to include diverse perspectives to ensure culturally and linguistically relevant service delivery to people with substance use disorders, to stand peer recovery services independently of treatment with targeted funding, let people who are directly impacted have resources to do work in communities, think outside the box, working with those who have historically been left out, creating a more diverse workforce. And this would also pertain to again, to our BIPOC communities and our LGBTQIA communities, youth communities, etc. Folks who haven't been well represented in peer delivered services across the state. Support PRSS training events, including train the trainer programs with technical support for other trainers. This would support a more diverse PRSS workforce within underrepresented communities. There is a plethora of research and guidance from SAMSUB listed on there. And then if we could just skip to, and if anybody has any additional references to include, please send them my way. Then as far as scoring, the rationale behind that, I scored it a 3 on urgency because people are dying. I wrote, people continue to die as policymakers who are removed from the boots on the ground struggles, play catch up with old data, and try to guess what people need. People with living and lived experience have experiential knowledge to guide them. The people closest to the problem are always the ones closest to the solution. Rated 3 due to urgency of life or death. Impact, including a diversity of perspectives of people with living or lived experience, will have a positive impact on policy, funding, and programmatic decisions. Rated as 2 due to bureaucratic red tape and competing funding priorities, i.e. like we've seen this with the money going to treatment rather than harm reduction or recovery support services. Capacity to implement, given funding, there would be capacity to pay people with living or lived experiences, subject matter experts, pay PRSSs a living wage by increasing reimbursement rates, and expand PRSS train the trainer offerings across the state, especially to underrepresented communities. So I'd just like to open this up to discussion and any kind of revisions that might be needed, including revisions to the scoring.
Madam Chair, Kelly Marshall for the record. Would you want me to take Assemblywoman Claire Thomas's note from Laura Hale and and indicate that DHHS could be asked to do a fiscal note?
Yes, please, Kelly. I think Assemblywoman Thomas's recommendation should probably be included in our recommendations going forward. I think that's a great suggestion. And we appreciate you because you are boots on the ground in how all of that process works. So super glad you're here.
Jeff Iverson for the record.
Hi, Jeff.
I think the impact that this will have on the people in our state is a 5 out of 3. But after I read your description here of why you gave it a 2, I do understand that. But if there's no other comments or questions, I would definitely make a motion to move this forward as is.
Thank you, Jeff. Well, I'm just going to jump in and second your motion, Jeff. And we will move it to a vote. All in favor of moving this recommendation forward, please state aye.
Aye.
Any opposed? All right, we have got through. I'm so proud of us. I'm so proud of all of you and your discussion and your passions and your contributions. And we've gotten through all of our 2023 recommendations for that agenda item. And we're going to move now. I mean, look at us. We've got a quorum even. We're going to move to the next agenda item, which I don't remember what number it is. I'm so sorry.
So, Madam Chair, I believe it's agenda item 5, Kelly Marshall for the record.
Perfect. Thank you. Agenda item number 5. And we are looking at additional recommendations for review and discussion. And just to clarify, these are the ones we did not get to during our last meeting.
Yes, so Madam Chair, Kelly Marshall for the record. So there were 2 recommendations. One was sent forward by the prevention subcommittee, and this alternative pain treatment recommendation was first heard by the full SURG, and then it was sent, I believe, to prevention, and then they forwarded it to this subcommittee, and the next recommendation was also forwarded as well. There we go. So we have not workshopped this with a quorum, and obviously there is no survey response as a result. So you may want to identify a sponsor, or you may want as a group to do a rating. Or you could just say that you want to move this forward to the SURG in October and pending a survey response with identified sponsors that could be discussed at your October meeting.
Thank you, Kelly. So it sounds like we have quite a few decisions to make. One is, do we move this forward? And 2 is, how do we move this forward if we decide to move it forward? So looking at this recommendation, this was from Dr. Nairizi's presentation on alternative pain treatment. And this includes, I believe he also included, and I didn't see the presentation because it was for the prevention subcommittee. But knowing Dr. Nairizi, he also will prescribe a very limited dose of opioids for acute pain, moving forward with longer term pain management strategies that don't involve opioid analgesic drugs. And so this was, like Kelly said, a recommendation that came forward from the prevention subcommittee. They thought it would be more relevant to I saw you, so you
Yeah.
wave your finger.
I'm-
Did I
I'm
get that
sorry.
right?
No, I think I got it wrong. So Kelly Marshall for the record. Actually, Dr. Nyrizi came and presented at a treatment and recovery subcommittee that was chaired by Steve Shell in
Oh,
your absence.
sorry.
So I
Got
believe
it.
it was July. So I think it's the next one that was forwarded to us.
Oh, great. My apologies. I missed that.
No,
you
that
know?
was
I was
my
having major surgery. So my apologies. Yeah, I did miss that presentation. Okay, so it was bounced over, this recommendation was bounced over to another committee who thought it fit more with us. And so I guess the question to all of you is, do we want to move this forward? And then we'll talk about how. So just check in your appetite for this one.
All right, this is Dr. Dixon. Well, I think this is really important and I mean, you know, people still have a lot of pain and we, this has always been a problem where, you go to an ER, a primary care doctor, and they just give you narcotics and then we have some really well-trained pain treatment type people who could do other things, make other recommendations, and insurance won't pay for it. So, or you have to go through the prior authorization process, which takes time. So I think, yeah, I guess we're the right subcommittee to deal with this, to make this recommendation. So I agree with it.
Thank you, Dr. Dixon. Is there any other discussion on this one? Well, if I could, as a person in long-term recovery, I do feel it does, it took myself convincing myself that it does belong here, but I do think it belongs in treatment and recovery, for the fact that a lot of us got to where we are by being prescribed opioids, being overprescribed opioids. And so there's a lot of medical trauma that a lot of us have. And for chronic pain issues, it's good to hear about providers that are doing it in a different way, that is much less harmful to folks who need their pain to go away, but don't necessarily need to have, fall into another pattern of behavior where you have a chaotic relationship with drugs again. And so I think it does belong here, and I think we should push along. I saw you come off mute, Assemblywoman Thomas.
Yes, thank you, Assemblywoman Thomas. For the record, I really can't make a, since I have never been where you all are, or, been in the medical field, I just don't feel that I'm the education on seeing or hearing this presentation for me to make a recommendation. I'm not that person that just goes along with something. So I would actually have to review and listen and then make my determination of whether or not I would like to go along with this recommendation. So for right now, I'll abstain.
Jeff Iverson for the record. I agree with both Dr. Dixon and Assemblywoman. I think that this is all really important for discussion and to think through further, but I don't know that we're ready to move this forward as is. Those are my thoughts.
Is there anything down further down, or is this it?
Kelly Marshall for the record. So no, we did not have a quorum when we were discussing this, so we were not able to identify a sponsor and have the rest of this filled out. I will note that, as stated previously, Dr. Nyrizi presented at the April SURG meeting, and then I believe it was the July, it was July at the treatment and recovery subcommittee meeting, and that recording is posted. So he's presented twice, once to the full SURG and once to this subcommittee.
Thank you, Kelly. And thank everyone for offering your point of view on this. I think Assemblywoman Thomas, I think you make a really great point. That there is a lot of things that none of us know about this. And so like I would be comfortable moving the last bullet point forward, right? Include training on opioid stewardship, provider training on alternatives to opioids, patient education materials on tapering and options for pain management. I feel like that should have been done in 1999 when we first started, right? Like this is long overdue. I don't think we would be at almost 110,000 overdose deaths every year had we had that piece long ago, rather than, just cut people off and have them go into an illicit market that's unregulated and dangerous. Right. I mean, that piece right there, like grinds my gears because we've needed that for a long time. The other pieces I'm less certain of, right? I need more information about those things, but that one I know for sure. And I'd be willing to put forward that because it's been a long time coming and a lot of doctors just got entirely scared by what was happening. And unfortunately, a lot of folks are not, they'll never be around a family table again because of those decisions. And so if we could move forward something like that to offer to get doctors more comfortable, right? I mean, even identifying folks and using the expert seems to be an uphill battle in this state. But then what do they do? Like we really need to press forward on provider education. That's just my 2 cents.
Jeff Iverson for the record. I just saw, so I agree with that last bullet point, and then the additional 3 on the second page that I just noticed, I apologize. I could definitely get behind moving those bullet points forward.
This is Dr. Dixon. Well, let me say something about the first one, which of course I'm very much in favor of. The first bullet point. This is a heavy lift, very heavy lift. And, we, with the Psych Association, we managed to get a bill through that took several years this past session to eliminate prior auth and step therapy for psychiatric medications because they really can slow down treatment. But it was, like I said, it was a real heavy lift to get rid of prior authorization. And so we were very happy that we got the legislation through. So persuading insurance carriers to sanction opiate alternative treatments, well, they will tell you that all of them are more expensive than narcotics. And but I mean, it's a long-term goal. I think we work in the business need. We need to treat people better. We need to send them for, physical therapy and massage therapy and acupuncture, all these other things that work but cost a little bit more than narcotics. And but it may be not the time for us to do this. I don't know.
Thank you, Dr. Dixon. That is an excessively heavy lift, and definitely maybe short-term, it's a short-term higher expense, but a long-term lower expense. It's just getting them to insurance companies to see that. Yeah, what do we want to do with this one? I mean, it sounds like we could probably use some more information, is what I'm hearing from folks. That we could, take our time and digest this a little bit further and not rush it. I'm a fan of doing it right the first time. And maybe we could workshop this and bring it forward for our 2024 recommendation. Or we can jam it through now. It's really up to this committee how we want to proceed. And so, sorry, to follow up on that, I guess we can have a motion. I'll entertain a motion in either direction, whether to proceed with this or workshop it, for a 2024 priority.
This is Chelsea. I'm going to motion that we workshop this for 2024 and we try to get some more presentations and speakers to kind of clarify what we would like to do with this.
Assemblywoman Claire Thomas, I second.
Perfect. Thank you both. So we have a motion by Chelsea, a second by Assemblywoman Thomas. All in favor of workshopping this for a 2024 goal. Please state aye.
Aye.
Aye. Any opposed? All right, unanimously, we will work on that. We'll just table that for now. Kelly, was there one more recommendation?
There's Kelly Marshall for the record. There is the other recommendation.
Okay, so this last recommendation, advocate for increased funding and resources to improve accessibility and affordability of SUD treatment programs, including detoxification, rehabilitation, and counseling services, establish partnerships with local health providers, mental health centers, and support groups to ensure individuals struggling with SUD have access to appropriate treatment and ongoing support. Promote the development and implementation of evidence-based intervention programs that address the underlying causes of SUD and provide holistic support to individuals in recovery.
And Madam Chair, this was referred to as the tin high recommendation.
Oh, perfect. Thank you. All right. Any discussion on this recommendation? All right, y'all, I'm going to jump in again. I'm so sorry. Lisa Lee for the record. So the first piece, I feel like this advocate for increased funding and resources around treatment. I feel like this is a recommendation that came out of the ACRN. I know it came out of our Washoe County opioid needs assessment as well. And so I'm wondering if there's kind of an opportunity in the works with ACRN or the Fund for Resilient Nevada and opioid abatement dollars to be tackling that one, that first bullet point. The second piece, I feel like this is what was tried with the IOTRCs, the Integrated Opioid Treatment and Recovery Centers, back in 2017, which was based on the Vermont hub and spoke model and never fully fleshed out in our state. It's like the hubs got set up, but then the spokes didn't really get set up. The state kind of moved on to CCBHCs, which maybe those are kind of spokes. I don't really understand kind of what happened with that. So I feel like there's kind of that. And I don't know how we can fine tune it to really address gaps in the current system. Oh, I lost it. And then the third bullet point, promote the development and implementation of evidence-based intervention programs that address underlying causes. So I'm assuming this is more the trauma-informed approach, working to tackle adverse childhood experiences through pediatric screenings. I don't really know. Just throwing ideas out there that we could kind of refine this recommendation.
So, Madam Chair, Kelly Marshall for the record. So I wanted to bring up this slide because this is how it was received from the prevention subcommittee. So 10 high is there is no hero in heroin, and they received a presentation that obviously I think this subcommittee has not had a chance to review. But it looks like it's specifically for geared towards heroin use.
Thank you, Kelly. I personally would need more data showing that heroin is the main driver of opioid related harm, because I can tell you right here in Washoe County that is not the case. Specifically looking at post-mortem toxicology, our heroin involved deaths have gone down, our fentanyl deaths have gone up, and our methamphetamine related deaths have gone up. There are new analogs that are being tested, such as nitazines, that we're also tracking, as well as xylazine. And so I would need more evidence that this is a need in our state to move forward recommendations. And so I would ask for more time to really work on this and research it and workshop it. But I am so curious to hear what you all have to say, and if this is ready to move forward in an additional recommendation.
Jeff Iverson for the record. So I apologize. I thought these 3 bullet points were a continuation of the previous page. These bullet points, you're saying that a 10 high is recommending this specific to heroin use?
So Kelly Marshall for the record. So Jeffrey, I have to beg like ignorance on this. So this is a presentation was done to the prevention subcommittee by There Is No Hero in Heroin.
Okay.
And so otherwise referred to as Chin High. They had 3 recommendations as part of their presentation. And so the subcommittee provided that recommendation to us and forwarded it to treatment and recovery, feeling like it was more appropriate for treatment and recovery.
Okay.
So I may have been remiss in not making that presentation, which is likely posted, available to this subcommittee so that you could cross-reference it with what's posted under the prevention presentations. But that may just reinforce Chair Lee's point that that more study or information might be needed for us to feel like we know what to do with this.
Jeff Iverson again for the record. I agree. I think that I'd like some more information on this. And I obviously missed it as well.
Well, this is Dr. Dixon. I feel like at least the first bullet point is somewhat in some of our other ones already. Particularly recommendation number, well, several of them actually. It's a very, very general and broad, and so we've been kind of addressing a lot of this in much more specific form with our other recommendations.
Sounds like we should get some more information and discuss this further. Jeff Iverson.
Thank you, Jeff. I'm in agreement. So I think at this time, if any of you would like to make a motion to either move this forward or workshop it for later.
Jeff Iverson, for the record, I'll make a recommendation to workshop this for later.
Perfect. We have a motion.
This Dr. Dixon, I'll second it.
And a second by Dr. Dixon. All in favor of workshopping this at a later date, please
Aye.
signify by stating aye. Aye.
Aye.
All right. And just for the record, Steve Shell had to jump off, so he is absent for that vote. It is unanimous with the remaining members.
And he jumped off at 2:55 for those
Perfect.
taking minutes.
Thank you, Kelly. All right, so moving on to agenda item number 6. Thank you everyone for jumping in there, and I like it. And Assemblywoman Thomas, thank you for saying like, hey, you know what? You gave us all permission to hit the pause button and get that additional information. I think that is super impactful. So thank you for that. I believe in the pause button. All right, moving on to agenda item number 6, discuss report out for October SURG meeting and next steps.
So, Madam Chair, Kelly Marshall for the record. I think the question is whether the group wanted to take the ratings, that consensus rating of the 3s, et cetera, and rank order or kind of prioritize one recommendation above the other, or if when you present at the October SURG meeting, if you just want to present them as a slate. As there likely would be some prioritization across the different subcommittees presenting. So I don't know that other subcommittees are going to say, here's our number 1, number 2, and I would remove the numbers and just say, here are the recommendations like A, B, C, D, E, in no particular order, unless you wanted us to structure them in some other way. And I would just invite Laura, I think she took herself off mute. Laura, if you want to help me out here.
Thank you, Kelly and Madam Chair. I don't believe that other subcommittees are bringing them forward with a ranking. I think the intent was with this new process that the subcommittees would do exactly what you've just done with looking at the qualitative justifications, and then when you look at them all together at the SURG level, then we would need to start looking at a ranking so you can figure out what 20 altogether are going to go forward with the SURG. So there isn't a requirement at the subcommittee level to do that, and I'm not aware of other subcommittees doing that.
Thank you, Laura. So I'll pose that question to the group if we would like to just have a slate of recommendations, and some not arranging them in any sort of hierarchy, just as our recommendations that we're moving forward, or if they need to be arranged as, kind of prioritized recommendations.
Well, this is Dr. Dixon. In the interest of time, now that we are
Yeah.
3 o'clock,
Yes. Uh-huh.
I think we ought to just leave them. Otherwise, we could spend another half hour trying to rank them. So
Yeah, I would agree, and I don't like hierarchies anyway.
yeah,
More
and
about-
incidentally, I'm not going to be able to be at that meeting. So
Okay. Thank you,
So-
Dr. Dixon.
yeah.
I mean, Jeff Iverson, for the record, I'm looking at them and I'm thinking, like, in my own mind, I can't really prioritize them because
Uh-huh.
they're all so important. So I think
Uh-huh.
not prioritizing them is probably the path of least resistance because they're all super important.
So Chair Lee, Kelly Marshall for the record, I think given that I don't know that you need a motion, I think it would just be important for you to share that there is no particular order, except I see Laura raising her hand.
I
So.
see Laura's hand. Yep.
Thank you, Madam Chair. I just wanted to remind members that the reason that the SURG will ultimately want to prioritize is twofold. One is to try to limit the number of recommendations that you put forward as a full SURG body. The second reason is in the last cycle, with the recommendations that went forward, there wasn't a prioritization process, and there was one recommendation for which not all members supported it. And so this is to try to have the report reflect the SURG as a whole, to what extent they are either prioritizing or agreeing on the recommendations that ultimately go forward. I hope that's helpful.
But
It is.
yes, Kelly Marshall for the record, but not necessarily from the subcommittee. So Laura, you're not saying, you're saying that's something that if it's done, should be done at the SURG, not at the subcommittee level.
100% correct, yes.
Okay, perfect. So to move this buggy forward, we're just gonna propose them as a slate. We'll leave that up to the SURG to figure out how this will be ranked in the future. All right, we are moving on to public comment, which I don't have the script for. I'm so sorry. Okay, so public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public till the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. So we will open it to public comment, and Kelly, I believe you have additional info.
If you're dialing in from a telephone in the US, please dial 1-253-205-0468. And then when prompted, enter the webinar ID 894-8937-5298. You can press *9 so the host can prompt you to unmute. So at this time, we would just ask anyone wishing to make public comment to either raise your hand, unmute yourself, or dial *9. And Madam Chair, I do not see anyone unmuted. Other than Laura, and Laura, I don't think you want to make public comment right now, but if you do, please do so. Oh, no. Okay, so no public comment.
No public comment, and we will go ahead and adjourn our meeting. We'll see you in October. Thanks, everyone. Thank you. Thanks for all you do.
Good night.
Bye, y'all.